In the last section, we talked about the angle of inclination and the angle of torsion when we're talking about the osteology of the hip, and how if you have deviations from the normal angle of inclination, it can affect hip and knee alignment and hip and knee stability. So, and the angle of torsion, the same thing. It can affect your hip and knee stability. So are we going to have any effect in physical therapy on someone's angle of inclination or angle of torsion? Of course not. We're not doing anything that's going to change their bones per se. However, we can work on balance and strength and other things to work on joint stability. So we do have supporting structures within the joint, some of them ligamentous and some other things, and we'll talk about those just in this little section. So for these different ligaments, what I want you to know about ligaments in general, of course we're going to talk about the ligaments of the hip here, but in general, ligaments their job is to prevent certain motions. They need to stabilize the joint. So they're going to prevent excessive motion in the joints. So when you're thinking about ligaments, the way I would suggest that you think about it is, what motion does this ligament prevent? Or what stability does this ligament add to the joint? It's another way to think of it. So in the study questions, there's a little chart with ligaments, and it says ligament and motion prevented. Or you can think of it as the function of the ligament. So we're going to look at it from that perspective. So the transverse acetabular ligament, it spans the acetabular notch, completing the cup of the acetabulum. So we have that lunate surface on the superior portion, and the transverse acetabular ligament goes on the inferior portion, kind of making that cup that the ball then fits in, the head of the femur. So basically, some ligaments do that, like we talked about the sacrotuberous ligament, which completes the arch on the greater sciatic notch. So some ligaments, that's what they do. They sort of provide stability by completing structures, if that makes sense. The ligamentum teres, it's a tubular sheath of connective tissue that runs from the transverse acetabular ligament to the femoral head fovea. So it basically is attaching it's the connective tissue attachment from the head of the femur to the acetabulum. And there's a branch of the obturator artery that travels through, which provides some of the femoral head blood supply. A lot of times in PT, when you see someone who is younger than 60 or 70 that has had a total hip replacement, most of the time they've had to have that total hip replacement is because of avascular necrosis of the femoral head. So something happened, some trauma or congenital defect happened that interrupted that branch of the obturator artery, and so the femoral head didn't have an adequate blood supply, and you get necrosis where the femoral head actually starts to break down. So that happened to my sister. She ended up having a total hip replacement when she was in her late 30s, and she's done really well with it. It's worked out really great for her. I've worked with many people in the clinic who had a total hip replacement for that very same reason. So a lot of times when you see someone in their 70s or 80s getting a total hip replacement, it's because they wore it out, osteoarthritis. When you see an earlier person, a lot of times it's because of interruption of this ligamentum teres, whether by trauma or by other means, and it causes avascular necrosis of the femoral head. So the acetabular labrum is a ring of fibrocartilage surrounding the outer rim of the acetabulum. We also have a labrum in the glenoid fossa, our other ball and socket joint in the body. And what the labrum does is it provides increased hip stability by deepening the socket and gripping the femoral head. So it's like a gasket for your hip, basically. It's our fibrocartilaginous gasket. And it deepens the cup and it grips the femoral head. So when you have a labrum tear, that causes instability. So because it's fibrocartilage, it doesn't have a great blood supply, it doesn't heal well. And so a lot of times labrum tears are not going to heal on their own, they require surgery. And what do you think we're working on in physical therapy? Can we affect their labrum? Probably not. We're working on strengthening the muscles to stabilize the joint. The articular cartilage of the hip covers the lunate surface, which is that superior surface of the acetabulum, and it acts as a shock absorber within the joint. It's thickest at the superior pole of the femoral head. So that's our shock absorber at the top of the hip joint. So we have big, beefy ligaments that are supporting the hip. The iliofemoral ligament, its name is the Y ligament because of its shape. It's a thick, strong ligament resembling an inverted letter Y. It attaches proximally to the anterior superior aspect of the acetabular rim and distally to the intertrochanteric line of the femur, which is that anterior imaginary line between the greater trochanter and the lesser trochanter. It limits excessive hip extension. That's its job. So it's big and huge, and it's going to keep us from falling over. So you can actually lean into your Y ligament pretty extensively and not use a lot of muscle force to stand up. The ischiofemoral ligament arises from the ischial portion of the acetabular rim, spirals around the femoral neck, and attaches near the apex of the greater trochanter. So when you look at the position of the iliofemoral ligament and the ischiofemoral ligament and the pubofemoral ligament, they're sort of spiraled around the neck of that femur, really holding that femur into the acetabulum. Very stable structure. So the ischiofemoral ligament limits extension as well as the iliofemoral ligament, and it also limits internal rotation of the hip. So when you look at of where it's located, it's that in this picture it's sort of behind the iliofemoral ligament, and you can see how that would limit internal rotation. It's going to limit the anterior portion of the femur moving medially in the transverse plane. You can kind of see that. The pubofemoral ligament arises from the anterior inferior rim of the acetabulum and attaches distally to the lower half of the intertrochanteric line of the femur. So that's that spiraling that I was talking about. It limits hip abduction and extension. So all three of those, iliofemoral, ischiofemoral, and pubofemoral, limit hip extension. So we've got three huge beefy ligaments, one with two legs, limiting hip extension. And then the pubofemoral limits abduction, and the ischiofemoral limits internal rotation. So big beefy ligaments to limit the motion at the hip. So when you compare the motion of our two ball and socket joints, our shoulder joint and our hip joint, big difference, right? The shoulder's got way more than the hip, but the hip has to be stable because we're not walking around on our hands. So there's a little blurb in the book about the muscular efficiency of standing at ease. And when they say at ease, it means that if you stand in good upright posture, most adults can stand for a long time using minimal amounts of muscular energy. When you're standing in good upright posture, the line of gravity normally travels to just posterior to the medial lateral axis of rotation of the hip. And we can kind of use the greater trochanter as a landmark for that. So the line of gravity, and this summer in Test and Measures Lab, Lisa and Claudia will have you do some plumb line posture assessments, and you'll see how this works. So gravity provides a passive extension torque at the hips, which, if not opposed, would cause backward bending of the pelvis over the femurs. So because the line of gravity is slightly posterior to the medial lateral axis, we need the Y ligament and the pubofemoral ligament and the ischiofemoral ligament to keep us from going into excessive hip extension. So we can actually hang on those ligaments a little bit to keep us in an upright posture. So all three of those external ligaments of the hip are stretched in extension, and they create that passive rubber band-like flexion torque at the hips. So tension between the stretched ligaments of the hip and the action of gravity allows us to stand with very little muscular intervention. So here's the picture of the guy with paraplegia who's using the Flexion crutches. By shifting his body weight forward of the medial lateral axis, he's actually able to stand without having good functional muscles in his lower extremities, and the Flexion crutches act for balance. So because we have that passive flexion torque at the hips, that allows us to stand with very little muscular intervention. So if you have a hip flexion contracture, in other words, you have limitation of your passive hip extension because you have lack of extensibility in the hip muscles or ligaments, that passive standing mechanism is disabled. You can't shift your hips far enough forward to get that line of gravity posterior to the medial lateral axis, and the result is that you need continuous activation of your hip and back extensor muscles to maintain an upright position. So I was saying this in the muscle chapter, walking around with your hips and knees flexed takes a lot of energy. But take a look at your favorite elderly people, and a lot of them walk around with hips and knees in a little bit of flexion. And so it takes more energy for them to walk around, therefore they get tired quicker. So if we can help them out by strengthening their hip extensors, strengthening their knee extensors, and stretching their hip and knee flexors. So that is one of the things that I've seen recently, which I thought was pretty cool, is there's some manufacturers who manufacture equipment for elderly or disabled people. They've developed, they said, because a lot of the designers of this equipment are young people, they don't understand what the challenges are when you have these limitations. So somebody developed a suit where you can kind of tighten down straps and make hip and knee flexion contractures, and then try to do things and try to use the equipment. And it can be really eye-opening for a young person who doesn't experience these things to see how much energy it takes to be an old person if you have hip flexion contractures and knee flexion contractures.